Imagine walking into like a highly sanitized state-of-the-art clinic, and a medical team takes a vial of cells that were harvested and meticulously cultured from the discarded umbilical cord of a healthy newborn.
Right.
And they take those vibrant, day-old cells and inject them directly into an arthritic 60-year-old knee. Or maybe, they deliver them through an IV drip to a patient who's suffering from this cascading autoimmune disorder.
It sounds totally like science fiction.
It really does. I mean, to a lot of people, it also sounds like a regulatory nightmare. But right now, like literally this very week, thousands of patients are boarding flights to Guadalajara, Mexico to do exactly that.
Yeah, it is a striking visual, and it really underscores this massive paradigm shift that's happening in real time. Because, think about it. We have spent the last century perfecting a medical model that is basically just based on suppression and management.
Oh, 100%.
Right. Like, if your joint is degrading, we give you a corticosteroid to artificially suppress the inflammation. If your immune system is overactive, well, we just use pharmaceuticals to blunt the entire system.
They just mask the pain.
Exactly. We mask the pain, we lower the volume of the symptoms, and we just try to make the inevitable decline as tolerable as possible.
Which is incredibly frustrating for patients who don't just want to tolerate their decline.
Nobody wants that.
No. And if you're listening to this right now, I'm probably voicing your own internal skepticism, right?
Yeah.
Like, if there is a way to actually support the body's native repair mechanisms, why is the standard of care still just handing out prescriptions to numb the pain?
Right. Why hasn't my specialist in Chicago or Toronto offered me this?
Exactly. And that regulatory elephant in the room is exactly what we are confronting in our deep dives today. We're looking at the PlacidWay Pulse materials, and specifically at the landscape of regenerative medicine abroad. We're going to focus heavily on a facility called Cellstime Clinique in Guadalajara.
Which is doing some fascinating work.
They really are. They specialize in mesenchymal stem cell therapy, exosomes, and growth factors.
But before we tear into the biological mechanics of how those therapies actually function in the body, we have to lay down the absolute non-negotiable ground rules for this exploration.
Yes, very important.
The materials we are analyzing today are strictly educational. We are dissecting the science, the logistics, and that rigorous vetting process you need for international medical travel. We are not providing medical advice,
Right.
And we are definitely not recommending any specific intervention.
Yeah, you cannot just listen to an analysis of stem cell therapies and decide to, book a flight tomorrow. Your primary care physicians and specialists, the ones who hold your complete medical history, they absolutely must be part of your decision matrix.
Totally.
Our mission here is to arm you with the highly technical vocabulary and the critical frameworks you need to interrogate these clinics, demand transparency, and ultimately protect your own biology.
Because a fully informed patient is a protected patient. And, to become informed, we really have to move past all those marketing buzzwords.
Oh, the buzzwords are everywhere.
Right. You hear regenerative medicine, and you might picture like a lizard regrowing a tail.
Right, like Spider-Man science or something.
Exactly. But that is not the clinical reality. The therapies offered at places like Cellstime Clinique in the Puerto de Hierro district of Guadalajara, they are deeply rooted in cellular biology. They focus on biological materials that modulate the environment inside your body.
Okay, let's unpack this. Let's strip away the marketing and look at the raw science here. The PlacidWay Pulse material highlights mesenchymal stem cells, or MSCs, as basically the cornerstone of this clinic's approach.
Right.
Now, we know you're likely already familiar with the broad strokes, that stem cells are the body's master builders. But let's look at the actual mechanism. How does an MSC actually execute a repair? We hear the term multipotent, meaning it can differentiate into bone, cartilage, or fat. But it isn't just floating around randomly deciding to turn into a piece of cartilage, right?
No, not at all. The mechanism is entirely dependent on the microenvironment. MSCs are incredibly sensitive to chemical gradients in the body.
Okay.
So when you have tissue damage, say a micro tear in a ligament or severe inflammation in a joint capsule, those damaged local cells release specific cytokines and chemokines.
Which are like signals.
Exactly. Think of them as chemical distress flares shot up into the surrounding tissue.
Okay, so the MSC has to somehow detect those flares.
It does. MSCs possess these receptors on their cell surface that detect those specific distress signals. And this triggers a process called homing.
Homing, like a homing beacon.
You got it. The MSC migrates up the concentration gradient of those chemokines, moving directly toward the site of maximum damage. And once it arrives at that injured tissue, The local environment dictates its behavior.
Wow.
Yeah, the surrounding cells, the oxygen levels, the mechanical stress of the area, all of these factors force the MSC to alter its gene expression.
So if it arrives in a damaged knee joint, the specific chemical signature of the dying cartilage forces the MSC to, like, differentiate into a chondrocyte.
Right, a cartilage cell.
So it differentiates into that to patch the hole.
Well, that is the differentiation pathway, yes. However, the current scientific consensus suggests that differentiation is actually only a fraction of how MSCs truly work.
Wait, really?
Yeah. In many cases, the MSC doesn't become the replacement tissue at all. Instead, it acts as an on-site biological manager.
A manager.
Yeah. It arrives, assesses the inflammation, and begins secreting its own massive array of proteins, immunomodulatory factors, and signaling molecules. It calms the hostile, inflamed environment down enough so that the patient's own native surviving cells can wake up and resume the healing process.
Oh, wow. Which brings up a critical fork of the road for any patient researching this, right? If my native cells are exhausted or, if I am in my 60s or 70s, my own MSCs are going to be tired too, right?
Yes, precisely.
This is the whole debate between autologous cells, taking them from your own body, and donor-derived cells, or allogeneic cells. Why would a clinic recommend one over the other?
It all comes down to cellular vitality and something known as the Hayflick limit.
The Hayflick limit.
Yeah, so every time a cell divides, the protective caps on the ends of its DNA, the telomeres get slightly shorter.
Like the plastic tips on a shoelace.
Great analogy, exactly. And eventually those telomeres are gone, the cell can no longer divide, and it enters a state of senescence. It basically stops working.
Wow, okay.
So if you are 65 years old, your autologous MSCs, whether they extract them from your bone marrow aspirate or your fat tissue, they have been dividing and weathering systemic stress for over 6 decades.
So they're just exhausted.
Right. They have shorter telomeres, their replication rate is slower, and their secretion of those vital healing proteins is severely diminished.
So even if a lab extracts them from my fat tissue and cultures them, they are just multiplying exhausted 65-year-old cells.
Precisely. You might yield a high absolute number of cells, but their biological horsepower is compromised. And this is why clinics like Celltime heavily utilize donor-derived MSCs.
Okay, that makes sense.
Yeah, typically they're sourced from Wharton's jelly, which is this gelatinous tissue within a donated umbilical cord from a healthy, full-term C-section pregnancy.
Right.
These are day zero cells. They have maximum telomere length, immense proliferative capacity, and they secrete anti-inflammatory cytokines at a rate that is vastly superior to aged autologous cells.
But wait, if you inject someone else's DNA into my body, why doesn't my immune system immediately flag it as a foreign invader and attack it? Like if I get a kidney transplant, I have to be on immunosuppressants for the rest of my life.
That is the genius of the mesenchymal stem cell.
Yeah.
MSCs are generally considered immune privileged or, more accurately, immune evasive.
Immune evasive. Okay.
Right. They do not express the major histocompatibility complex or MHC class II molecules on their surface. And those are the specific markers that your immune system's T cells use to identify foreign tissue.
So they just don't have the red flag on them.
Exactly. Furthermore, they actively secrete factors that suppress the local immune response. They essentially wear a chemical cloak of invisibility while simultaneously telling the host's immune system to stand down.
That is fascinating. So the clinic is leveraging the vitality of newborn tissue without triggering a rejection cascade.
You got it.
But the PlacidWay materials note that Cellstime Clinique doesn't just rely on the whole MSC. We need to talk about exosomes, because the whole concept of exosomes is exploding in the literature right now.
Oh, absolutely.
The easiest way to conceptualize them is as cellular text messages, but we really need to dive into the actual biological payload they carry.
Right, so exosomes are extracellular vesicles. When an MSC is functioning, it creates these tiny nanoscale lipid bubbles.
Okay, bubble.
And the lipid bilayer of the exosome protects its contents from being degraded by the enzymes in your bloodstream. Inside that protective bubble is the payload messenger RNA, microRNA, and hundreds of different signaling proteins.
So if the MSC is the cell managing the construction site, the exosome is the actual blueprint and the work orders being sent out to the local tissue.
That's spot on.
But how does an RNA packet floating in the joint fluid actually alter the behavior of a damaged cell?
It is a literal cellular hijacking, but for therapeutic purposes.
Hijacking.
Yeah. So the exosome floats through the extracellular space until its lipid membrane merges with the membrane of a damaged target cell, say a highly inflamed joint cell.
Cool.
The exosome dumps its payload of microRNA directly into the target cell. That microRNA then binds to the target cell's own messenger RNA, effectively silencing the production of pro-inflammatory proteins.
Wow.
It literally intercepts the damaged cell's genetic instructions and rewrites them, forcing the cell to stop destroying itself and start repairing.
Which means, theoretically, you might not even need the live stem cell. If you just harvest billions of these exosomes in a lab and inject the text messages, you could trigger the repair without the complex logistics of keeping live cells viable.
That is the exact frontier of cell-free regenerative medicine, and why clinics feature them so prominently. What's fascinating here is that exosomes carry zero risk of unwanted cellular differentiation, because there is no live cell to mutate.
That's huge.
And they can cross the blood-brain barrier more easily due to their microscopic size, but, and this is a massive caveat, they are only as good as the lab that produces them.
Right, because of the environment they're made in.
Exactly. You have to ask, what was the parent stem cell exposed to in the bioreactor to force it to produce those exosomes? If the lab doesn't stress the parent cell correctly, the exosomes it secretes might carry a completely useless payload.
Wow. Okay, and then we add growth factors into the mix. If exosomes are the blueprints and instructions, I suppose the growth factors are the biological funding, like they are the chemical currency that pays the local cells to work overtime.
A very apt analogy. Growth factors are these heavy, complex proteins that force local cells to undergo angiogenesis, the creation of new blood vessels.
Which brings the oxygen and nutrients.
Exactly, to the dead zone. They stimulate the proliferation of fibroblasts to lay down new collagen scaffolding. Cellstime Clinique and similar providers often use a combinatorial approach.
Right.
The MSCs provide the ongoing management, the exosomes provide the rapid genetic reprogramming, and the growth factors provide the immediate metabolic fuel for the native tissue.
Okay, so the underlying mechanism is incredibly sophisticated. It isn't just, inject cells, feel better. It is a highly coordinated, multi-layered biological intervention.
Very much so.
So let's pivot from the microscopic mechanisms to the macro reality of the patient. Why are people seeking out this specific cascade of biological events? Let's look at the orthopedic applications first, because trying to save a joint from the surgeon's saw seems to be the primary catalyst for medical travel.
If we connect this to the bigger picture, the orthopedic patient is usually someone who has absolutely exhausted the standard algorithmic approach.
Right, they've done it all.
They have done the physical therapy, they have taken the NSAIDs, which are wrecking their stomach lining, they have endured the hyaluronic acid injections, and the corticosteroid shots have eventually caused the cartilage to degrade even faster, which is a known paradoxical side effect of repeated steroid use.
Which is just wild to think about.
Yeah.
So they're basically facing a total knee or hip arthroplasty, a brutal structural amputation and replacement with titanium and plastic.
Yes, unfortunately. For these patients, the localized injection of MSCs and exosomes directly into the synovial fluid of the joint capsule is a final attempt to alter the hostile microenvironment.
Okay.
The goal is that the exosomes will downregulate the catabolic enzymes that are actively chewing up the remaining cartilage, while the growth factors stimulate the native chondrocytes to attempt structural repair.
I want to challenge the efficacy here a bit. Can a localized injection of cells actually regrow a destroyed meniscus or fill in a massive pothole of missing cartilage in a bone-on-bone knee?
The honest clinical answer is it is highly variable. Complete structural regrowth of massive cartilage defects is rare, and it's not the primary metric of success.
Okay, so what does this all mean for someone who is desperate for relief?
What these therapies can often achieve is a profound, sustained modulation of the inflammatory environment. Even if the MRI doesn't show a brand new, thick layer of pristine cartilage 6 months later, the patient might experience a complete cessation of pain and a return of mechanical function.
Rust from lowering the inflammation.
Right, because the synovial fluid is no longer a toxic, acidic bath of inflammation. The joint isn't new, but it's functional and painless.
That distinction is so crucial. You aren't buying a new knee, you are buying a functional biological reset.
Exactly.
But the orthopedic side is the easy stuff compared to the systemic and wellness applications. PlacidWay Pulse notes that clinics like Cellstime are treating patients for complex systemic issues, autoimmune conditions, neurological degradation, and severe chronic fatigue.
This is where the biological complexity scales up exponentially. With an autoimmune disorder like rheumatoid arthritis or multiple sclerosis, the patient's immune system has lost its self-tolerance.
It's attacking itself.
Yes, its T cells are actively hunting and destroying the body's own tissues, and standard medicine responds with systemic immunosuppressants, which leave the patient vulnerable to infections and cancers.
So if a patient travels to Guadalajara for a systemic issue, they aren't getting a localized injection. They're receiving these donor MSCs and exosomes via an intravenous drip.
Right, then I voy.
How on earth do the cells floating in the bloodstream know how to fix a systemic immune error?
They rely entirely on that homing mechanism we discussed earlier, but on a macro scale. When infused intravenously, a large percentage of the MSCs are initially caught in the capillary beds of the lungs. That's the pulmonary first pass effect. But even from the lungs, they sense the systemic inflammatory cytokines circulating in the blood. In response, they begin dumping massive amounts of immunomodulatory factors into the bloodstream. They secrete molecules like prostaglandin E2 and indoleamine 2-fucr3 dioxygenase.
Okay, you need to translate that biochemistry for me. What do those molecules actually do to a rogue immune system?
They force the aggressive tissue-destroying T cells to undergo apoptosis-programmed cell death.
Oh, wow. They kill off the bad actors.
Yes, and simultaneously, they stimulate the production of regulatory T cells, or TREGs. TREGs are the peacekeepers of the immune system.
The peacekeepers, I like that.
They travel throughout the body, forcing the rest of the immune system to stand down and restore tolerance. So the MSCs aren't fixing the damaged tissue directly, they are rebooting the patient's immune operating system.
That is profound. But we have to rein this in with the reality of biological variance. Because if I am suffering from an autoimmune disease that has robbed me of my mobility and my career, and I hear that a simple IV drip can reboot my immune system, I mean, I am going to empty my savings account right now. I am going to expect a total cure.
And that expectation is exactly where unregulated hope becomes dangerous. Biology is not engineering.
Right.
If you replace a faulty spark plug in a car, the engine runs. If you infuse 50 million highly viable day zero MSCs into a patient, the results are entirely unpredictable.
Because everyone is different.
Exactly. The patient's baseline metabolic health, their hormonal balance, the specific genetic expression of their autoimmune disease, all of these dictate the outcome. One patient might achieve a complete multi-year remission. Another patient with the exact same diagnosis might experience only a mild temporary reduction in fatigue.
Which means the single most important characteristic of a trustworthy clinic is their willingness to tell a desperate patient, this might not work for you.
100%.
If they market a 100% success rate, they are operating in the realm of fantasy, not science.
A responsible clinician deals in probabilities and realistic physiological outcomes. They will clearly delineate what is scientifically supported versus what is still considered experimental and highly speculative.
So if the outcomes are variable and the science is complex, we really have to ask the geographical question, why Guadalajara?
Right.
If you look at the medical travel landscape, patients are leaving highly regulated advanced healthcare systems in the U.S. and Canada. They are choosing to cross a border for a biological intervention. Let's unpack the regulatory environment that makes this necessary without getting into the politics of it. Why is Mexico the destination?
It comes down to the legal definitions of biological manipulation and lab expansion. In the United States, the FDA has very stringent regulations regarding how much you can manipulate a cell before it is classified as a biological drug.
Okay.
If you take bone marrow, spin it down in a centrifuge, and immediately inject it back into the same patient on the same day, that is generally allowed.
But earlier you said autologous cells in an older patient are exhausted and low in number.
Exactly. To get a therapeutic dose, say 50 to 100 million viable MSCs, you have to extract the cells, put them in a bioreactor in a laboratory, feed them, and force them to multiply over several weeks.
And that's lab expansion.
Yes. Under current FDA frameworks, the moment you extensively culture and expand those cells over days or weeks, they are classified as a drug. That requires massive, multi-million-dollar clinical trials for every specific disease indication before they can be offered commercially.
So the limitation isn't that the science is bad, it's that the regulatory framework classifies expanded cells as unapproved pharmaceuticals.
Correct. Mexico, however, operates under a different regulatory framework. COFEPRIS, which is the Mexican equivalent of the FDA, allows for the highly regulated licensed expansion of both autologous and allogeneic stem cells in certified cleanroom laboratories.
Oh, I see.
Clinics in Mexico can legally culture these massive, potent doses of day zero umbilical cells and administer them to patients.
Which perfectly explains the medical travel phenomenon. It isn't just about finding a cheaper treatment. It's about accessing a specific biological protocol, lab-expanded high-dose MSCs, that is legally inaccessible in the patient's home jurisdiction.
Precisely.
But why Guadalajara specifically? When the average person hears medical tourism in Mexico, they unfortunately still picture like a dusty border town where you get discount dental implants and cross back over by dinner.
And that stereotype is completely detached from the reality of Guadalajara.
Right.
It is the second largest metropolitan area in Mexico, deeply integrated into the global economy, and widely referred to as the Silicon Valley of Mexico. The technological and economic infrastructure there is immense, and that directly feeds into their healthcare system.
The PlacidWay pulse materials specifically highlight the Puerta de Hierro district where Cellstime Clinique is located.
Yes, Puerta de Hierro is an ultra-modern, affluent financial and medical district. You are looking at towering, glass-fronted private hospitals, specialized research laboratories, and clinics that are built specifically to cater to an international standard of care.
So we're talking world-class.
Absolutely. These facilities often share architectural and operational DNA with the best private hospitals in Houston or Geneva. Furthermore, the logistics of a major international airport make it highly accessible for a patient who is already physically compromised and cannot endure a brutal travel itinerary.
But the luxury Puerta de Hierro creates its own psychological trap, right?
Yeah.
We have to discuss the danger of convenience, because there are slick, manipulative clinics out there.
Oh, without a doubt.
A patient sitting in their living room in intense pain can easily conflate a beautiful website, a cheap direct flight, and photos of a gleaming high-rise with actual clinical safety.
It is the halo effect of modern marketing. A slick web interface does not equal a sterile ISO-certified laboratory. You cannot allow the convenience of an all-inclusive medical package to short-circuit your critical thinking. A patient's only defense mechanism is their paperwork and their relentless demand for data. If you aren't spending weeks compiling your medical records, verifying doctor credentials, and demanding laboratory readouts before booking a flight, you are flying blind into a biological intervention.
Which moves us out of the theory and into the actual execution. How does a patient survive this process? Let's trace the journey of a hypothetical patient, let's say a 55-year-old, with aggressive rheumatoid arthritis, navigating the PlacidWay framework from their living room to the clinic in Guadalajara.
Okay, let's do it.
It starts with the initial data gathering, the formulation of the medical dossier.
And this step is where legitimate clinics separate themselves from the predators. A legitimate clinic will place an immense administrative burden on you before they ever discuss pricing or travel dates. They require a comprehensive medical dossier.
We aren't just talking about a doctor's note that says patient has joint pain, right? What exactly does a Mexican clinic need to see from a U.S. or Canadian patient?
They need high-resolution imaging, recent MRIs with the radiologist's complete readout. They need comprehensive blood panels.
Okay.
For an autoimmune patient, they need to see your specific autoantibody markers, your inflammatory markers like CRP and ESR, and a complete metabolic panel. Crucially, they need a granular, precise list of your current medications.
Why is the medication list so vital? Are there contraindications with stem cells?
Absolutely. If a patient is on heavy biological immunosuppressants for their rheumatoid arthritis, those medications might actively destroy or neutralize the infused donor MSCs before the cells can even begin to home to the inflammation.
Oh, wow. So you could just kill the treatment right away.
Right. Or if a patient is on systemic blood thinners, the physical act of a deep joint injection or a port placement carries unacceptable hemorrhagic risks. The medical records dictate the biological feasibility of the entire endeavor.
So the patient submits this massive dossier. The clinic reviews it. Then comes the virtual diagnostic, the online consultation. This is the patient's first direct interaction with the medical team. What should the patient be listening for on this call?
You are listening for nuance and hesitation. If the doctor looks at your complex, decade-long history of rheumatoid arthritis and immediately promises that a single IV infusion will put you into permanent remission, hang up the phone.
Run away.
Yes. You want a physician who acknowledges the complexity of your blood work, explains exactly how the proposed cells might interact with your specific inflammatory markers, and discusses the very real possibility of failure or the need for multiple spaced-out interventions over a year.
Here's where it gets really interesting. If the virtual consult goes well, the clinic issues the formal treatment plan. This cannot just be an email with a price tag. What are the mandatory structural elements of a legitimate treatment plan?
It must be a highly technical written protocol. It must state the exact cellular product, for example, 100 million allogeneic Wharton's jelly-derived MSCs.
Okay, so very specific.
Exactly. It must state the exact viability percentage guaranteed by the lab, meaning what percentage of these cells will actually be alive and functional upon injection. It must detail the delivery vector. Is it intra-articular, intravenous, or intrathecal?
How they actually get it into you.
Right. It must list the inclusion of any secondary biologicals like exosomes or specific growth factors, and it must legally outline the procedural risks, the exact downtime, and the complete financial cost.
It is basically the architectural blueprint of the intervention. Now, let's assume the patient agrees. They book the flights, they navigate the logistics of traveling while physically compromised, and they arrive in Guadalajara. They walk into Cellstime Clinique. This is where the ultimate safety net must deploy the in-person evaluation.
Yes. Up until this moment, the clinic has treated a ghost. They have treated a collection of PDFs and a face on a video screen. The ethical mandate of regenerative medicine dictates that upon arrival, the medical team must halt everything and physically examine the patient.
Even though they already reviewed the MRIs and the blood work, why duplicate the effort?
Because a PDF does not tell you if the patient developed a systemic infection on the flight over.
Ah, right.
An MRI from 2 months ago does not reveal if the joint effusion has dramatically worsened. The clinic will often redraw blood, run rapid localized labs, physically palpate the joints, and check the patient's immediate vitals.
And what if the in-person reality doesn't match the paperwork? What if the patient arrives and their blood pressure is through the roof, or their white blood cell count indicates an active, silent infection?
Then a responsible medical director cancels the procedure. Period.
Wow.
Even if the patient has spent $10,000 on flights, hotels, and deposits. If the biological environment is hostile, infusing vulnerable stem cells is not only a waste of the patient's money, it is a massive clinical risk. The willingness of a clinic to say no to a patient standing in their lobby is the absolute highest indicator of their medical integrity.
That is a terrifying scenario for a patient, but a totally necessary one. This leads us directly into how a patient builds their own defense system. We need to formulate the interrogation. If you are sitting across from the international patient coordinator or the lead physician at a clinic in Guadalajara, you cannot be passive. You must interrogate their laboratory standards.
The laboratory is the beating heart of any regenerative clinic. The clinic could look like a 5-star hotel, but if the lab is subpar, you are injecting dangerous biological waste into your body.
So what are the highly technical questions a patient must demand answers to?
First, you ask for the lab certifications. Are they operating an ISO-certified cleanroom? What class of cleanroom is it?
Right.
Second, you ask about their cell expansion protocols. Do they use animal products like fetal bovine serum to feed the cells during expansion? Or do they use human platelet lysate?
Why does that matter?
Animal products carry a risk of xenogenic immune reactions.
Got it.
Third, demand to know how they test for sterility. Before those cells leave the lab, are they subjected to rigorous endotoxin and mycoplasma testing to ensure absolutely no bacterial contamination occurred during the weeks of culturing?
You essentially have to act like a regulatory auditor. And what about the actual personnel?
You ask, who is the specific individual inserting the needle into my joint or placing the IV? You want the name, the specific medical license number, and the specialized training credentials of the physician executing the protocol. You are not paying for a technician to practice on you.
Now, PlacidWay Pulse strongly advises taking this entire treatment plan, the lab data, the cell counts, the delivery methods, and presenting it to your home country specialist before you ever leave for Mexico. But I know exactly how that conversation goes for a lot of patients. They take this binder of Mexican stem cell research to their conservative rheumatologist in Ohio, and the doctor just scoffs, calls it snake oil, and tells them not to go. Why subject yourself to that demoralizing conversation?
This raises an important question, right? You are not going to your home specialist for validation or permission. You are going to them for contraindication screening.
Screening.
Right. Your home doctor holds your longitudinal health history. They know how your liver enzymes trend. They know the subtle quirks of your specific autoimmune presentation. Even if they are fundamentally opposed to regenerative medicine, you force them to look at the protocol and ask, based solely on my unique physiology, will this specific biological infusion interact catastrophically with my current systemic state or my current medications?
You just want their safety check.
Exactly. You need their skeptical baseline analysis of the risk.
That is a brilliant reframing.
Yeah.
You use their skepticism as a shield. Now, as you're navigating all of this, what are the glaring, non-negotiable red flags? What are the specific phrases or behaviors from an international clinic that should trigger an immediate cancellation of the entire process?
The most glaring red flag is the cure-all myth. If you look at a clinic's marketing materials and they claim that their specific proprietary stem cell infusion will simultaneously cure your localized osteoarthritis, reverse your systemic lupus, cure your macular degeneration, and treat your spouse's early onset dementia, you are dealing with a marketing firm, not a medical facility.
Because biologically, the mechanisms required to fix an avascular joint are completely different from the mechanisms required to cross the blood-brain barrier and halt neurodegeneration.
Exactly. A master key that unlocks every single biological lock simply does not exist.
Right.
The second red flag is aggressive financial pressure. Medicine is deliberate. If a coordinator tells you that a special discount on umbilical cells expires in 48 hours, they are using manufactured scarcity to bypass your critical vetting process.
They are treating a biological intervention like a timeshare presentation.
Yes, exactly. The third red flag is a refusal to document the exact provenance of the cells. If they claim their donor cells are superior, but they cannot produce the rigorous, multi-tiered viral and genetic screening reports of the donor umbilical cord proving it was screened for HIV, hepatitis, syphilis, and genetic abnormalities, you walk away immediately.
And finally, the before and after photos. PlacidWay warns against relying on these. A photo of a patient looking miserable in a wheelchair, followed by a photo of them smiling on a golf course in Guadalajara.
Contextless imagery is pure emotional manipulation. It tells you nothing about the patient's actual clinical diagnosis, their cellular dosage, their concurrent physical therapy, or the longevity of the result. Without longitudinal clinical data, a photograph is scientifically meaningless.
So, assuming you have interrogated the lab, consulted your skeptical home doctor, and successfully dodged every single red flag, and you have found a highly transparent, scientifically rigorous clinic, we have to confront the brutal, practical reality of medical travel, the logistics and the cost.
The financial architecture of international regenerative medicine is complex because it is entirely out of pocket. Your home insurance will not cover an experimental cell expansion in Guadalajara.
The quotes can vary wildly, too.
All right.
One clinic might quote $4,000, while Cellstime Clinique or another advanced facility might quote $15,000 or $25,000 for a complex protocol. What dictates that massive delta in price?
The delta is almost entirely found in the laboratory overhead and the biological yield.
Okay.
Creating a therapeutic dose of 50 million highly viable, sterile, donor-derived MSCs requires weeks of clean room bioreactor time, incredibly expensive culture media, and relentless safety testing. That is astronomically expensive. If a clinic is offering a massive systemic infusion for a few $1,000s, the math simply does not work.
So they have to be cutting corners somewhere.
They are either shortchanging the cell count, injecting mostly dead cells because they skipped the viability flow cytometry, or worse, they are bypassing critical sterilization and viral screening protocols.
Wow, that's scary.
In regenerative medicine, hunting for the lowest price is a dangerous, potentially lethal strategy. You are paying for the invisible rigor of the laboratory.
A transparent quote must itemize everything. The consultation fees, the pre-op blood work, the precise lab fees for cell expansion, the facility operating fees, the physician's execution fee, and the post-op medications. But the medical quote is only half the budget. The travel logistics for a compromised patient are a completely different animal than booking a vacation.
Oh, the logistical friction is immense. You have to consider the physical toll of commercial air travel on a body that is about to undergo, or has just undergone, a major biological intervention.
Right, the flight itself is stressful.
Cabin pressure and altitude can exacerbate joint swelling. Deep vein thrombosis is a very real risk if you are flying shortly after a massive infusion of biological material that might temporarily alter your coagulation profile.
Which means you cannot fly into Guadalajara, get an IV drip, and fly out the same afternoon.
Absolutely not. A responsible clinic will mandate a specific recovery window in Guadalajara, sometimes several days, where they monitor your vital signs, check the injection sites for infection, and ensure your immune system is not having an adverse acute reaction to the donor cells.
This necessitates highly specific accommodation planning. You need a hotel in Puerto de Hierro that is essentially adjacent to the clinic. You cannot be relying on a complicated network of taxis to get across a metropolis of 5 million people when you're experiencing a post-injection inflammatory flare-up.
And you must travel with a dedicated companion. This is non-negotiable for orthopedic patients.
Really?
Yes. If you receive bilateral knee injections of MSCs and exosomes, you will likely experience a temporary, acute increase in pain and stiffness as the local inflammatory response initiates the repair cascade. You cannot carry luggage. You cannot navigate a bustling international airport terminal alone. You need an advocate to manage the physical logistics of the return journey.
Which brings us to the most vulnerable phase of the entire process. You survive the flights, you get the treatment, you navigate the airport, and you finally arrive back home in Chicago or London. You are now thousands of miles away from the physician who altered your biology. What happens if, 3 weeks later, you spike a fever or a joint swells to twice its normal size?
This is why the remote follow-up protocol is just as critical as the laboratory standards.
Ah,
During the initial contract phase, you must define the post-treatment communication architecture. Does the clinic in Guadalajara assign a dedicated medical coordinator to monitor your progress for the next 12 months? Do they have a formal protocol for interfacing with your local primary care physician if an acute complication arises?
Because if they treat the final payment as the end of the clinical relationship, they are not a medical facility, they are a biological transaction hub.
Exactly. Regenerative medicine plays out over months, not hours. The cells take time to modulate the immune system and signal the local tissues. The clinic must be tethered to your recovery long after you leave Mexican airspace.
Navigating this entire labyrinth, the complex biochemistry of mesenchymal homing, the translation of international laboratory certifications, the defense against predatory marketing, and the logistical nightmare of flying while chronically ill is an overwhelming burden for a single patient to carry. And this is precisely where the utility of a platform like PlacidWay becomes evident. They are not the clinic. They are not the doctors. They are the informational bridge.
They function as a global aggregator and a logistical framework.
Right.
They allow a patient to look at the global landscape and ask, why Guadalajara instead of Panama or Colombia? What are the specific regulatory advantages here? Which clinics have transparently published their laboratory standards and which are hiding behind slick web design?
They provide the initial map through the wilderness, allowing you to focus your energy on executing the interrogation and consulting your home doctors, rather than just blindly searching for clinics on the internet.
They provide the structural framework, yes, but the ultimate responsibility of verification always remains with the patient.
So as we synthesize this deep dive into the PlacidWay Pulse materials, the overarching narrative is pretty clear. The utilization of mesenchymal stem cells, exosomes, and growth factors at international hubs like Cellstime Clinique in Guadalajara is not a fringe science fiction concept. It is a highly advanced, biologically sound frontier of medicine that attempts to repair rather than suppress.
It is a profound evolution in clinical strategy, leveraging the immense communicative and immunomodulatory power of day zero cellular networks to reboot failing biological environments.
But the access to that frontier requires you to adopt an almost militant level of vigilance. You cannot operate on hope, you must operate on data. You must understand the difference between autologous exhaustion and donor vitality.
Absolutely.
You must demand the laboratory credentials. You must brace for the reality of biological variance, understanding that there are no guaranteed cures, only calculated scientific probabilities.
And you must anchor your international journey with the skeptical oversight of your home medical team.
We want to thank you for enduring the heavy biochemistry and the intense logistical realities with us on this deep dive. The goal is always to empower you to navigate global healthcare options with absolute clarity, unyielding confidence, and profound care for your own biology. You can always visit PlacidWay.com to explore these options further.
As we conclude, I want to present a final concept for you to examine. We have spent this hour detailing the intense adversarial interrogation you must subject an international clinic to.
Right, acting like an auditor.
Exactly. You are demanding ISO certifications, flow cytometry reports, exact cellular payloads, and detailed systemic risk analyses. You are treating your biology with the utmost protective scrutiny.
You're acting as the ultimate, uncompromising auditor of your own healthcare.
Precisely. So the lingering question is this. If the perceived risks of crossing a border force you to become this highly educated, this fiercely demanding of transparency and scientific proof, how will that fundamentally alter the dynamic with your standard healthcare providers back home?
Oh, wow. That's a great point.
Once you have learned the anatomy of a true biological intervention, and once you have practiced asking why, and how exactly does this alter my cellular environment with such relentless aggression, you may find that simply accepting a 15-minute consultation and a prescription to numb your symptoms is a standard of care you are no longer willing to tolerate.